In this episode of Two Girls, One Pod, Angie and Yvie talk to Dr Andrew Orr. Dr Orr has a range of qualifications and degrees in medical science and women's reproductive health. However, Dr Orr is not an OBGYN nor a general practitioner, and what we discuss today is general only and not intended to be medical advice. Speak to your medical practitioner about what's best for you.
Hello and welcome to us. We've got a very special episode. I'm Yvie, that's Angie. She's in Turrbal land. I'm on Wurundjeri country. We don't want to muck around because we have a very special guest this week, and we are very excited about this particular topic because it's something very close to our hearts. So, Angie, if you'd like to do a lovely introduction for our guest, that would be wonderful because you're the one that's bringing our guest in this week.
I am, and I am so excited, grateful, blessed, all the feels that a man as wonderful as Dr. Andrew Orr will take time out of his busy schedule helping women and AFAB people all across the country for Endometriosis Awareness Month. We have Dr. Andrew Orr with us on Two Girls, One Pod this week. So a little bit about Dr. Andrew Orr. He has over 20 years experience in assisting with reproductive conditions, women's health conditions, pregnancy conditions, and many other women's health complaints. Dr. Orr has completed his master's level in post-grad training in both reproductive medicine and women's health medicine, and is also a member of the Fertility Society of Australia. I could seriously go on and on about him. He's also a qualified nutritionist, chef. He's got a science degree in food. So this man knows his stuff, and I'm very blessed to call him my women's health prac. So he's got it all. So I'm very blessed that he's taken the time to come on today. And we've got a bunch of questions for him. So shall we get this party started?
Yes, let's welcome him. Welcome, Dr. Orr.
Just in case people don't know what endometriosis is, what is endometriosis? What are the most common symptoms that you see? Just let's go with that, I reckon.
Well, endometriosis, the interesting thing about it is we still don't know much about where it comes from, how it evolves, only that it's sort of endometrial-like tissue, or as we say, normal-like tissue but growing in abnormal areas. But it can cause major symptoms like pain, bloating. So people often associate endometriosis with pain, but it's not always pain. It can be gastrointestinal symptoms, UTI-like symptoms without infections, called mood problems. It can cause, pain on bowel movements, pain with intercourse, which is a big one as well, and ovulation pain and IBS-like symptoms. It's a lot of people get misdiagnosed having IBS and they actually have endometriosis. And then a significant portion of women actually are asymptomatic, so they don't even know they've got it.
And they only find out when they're trying to conceive, or do they never find out? What's that process like?
Yeah, some will never find out, and we know that a lot of them will be only found out when they're going for fertility help with fertility, and we do investigations. So it's interesting that 50% of women laparoscoped for investigations for fertility will actually have endometriosis.
50%, that's huge.
It's huge, half.
So You just said then that laparoscopically that's the only way you can find it, isn't it?
Yeah, unfortunately, it's one of the misperception, I suppose. A lot of people think, I've had a scan, I've had blood tests, but it just can't. Unless it's deep infiltrating endometriosis, it can sometimes be seen on MRIs, but look, most women and menstruating persons will actually have superficial endometriosis, and that can't be seen on scans.
What's superficial?
Most of the superficial I wish I could share on my screen. But superficial is meaning that it's just on the superficial surface.
Right.
It hasn't sort of deep infiltrated into the tissue.
Of course, right.
And so the lesions are just sitting on the superficial side of the tissue.
And a lot of
Right,
people,
okay. Yeah.
I find, think that the more endometriosis that you have floating about, the more painful it would be. And if you only have a little bit, that means less pain. But after obviously doing a lot of my own research with having endometriosis myself, when I originally had my first laparoscopy years ago, I only had a little teeny tiny amount and I was in so much pain. And the next time I had it all through my bowel and I was in the same amount of pain. So there's kind of this misleading information out there. It's like if you've only got a little bit, you should only have small symptoms, which isn't the case at all. Why do we think people instantly assume that?
I think it's like when we've got a sore or a cut or something. They think the bigger the cut, the worse the symptoms. But with endometriosis, we know pain levels aren't related to the extent of the disease. And I've seen, women who have an obliterated pelvis.
Yeah.
And those women will have no symptoms at all.
Oh, my God.
Wow.
And then we'll see someone with a very, tiny, minuscule amount of it has lots of pain. And those women often get dismissed, especially if they've seen a practitioner or, a surgeon that's not quite capable of dealing with endometriosis and is stuck in some of the old school thinking as well.
And there's a lot of those, unfortunately. It's
Yes,
quite a
there
hard
are.
thing to find. Do you have hope for the future and the research that will eventually hopefully come where we can actually find these kind of things in scans with new equipment and things like that?
I do, because there's obviously genetic links, and we've known that for a long time, and there's hereditary links, and if your grandmother have it, there's a good chance your mother will have it, then you'll have it, and your daughter, and so forth. So, which suggests that it might be what we call a recessive gene that comes down through that way, and like I say to myself, we talk about hemochromatosis because a lot of women with endometriosis have low iron. I've got high iron, which is from a genetic condition. So those genes can be found. So my genetic condition can be found on a blood test. So surely at some stage when we identify the gene subsets that we would be able to identify it. Yeah.
Yes, that would be a game changer, because having something like a laparoscopy so often, which a lot of people do. I mean, I know people that have had them a few times a year. I've had one a few years in a row. It can be quite detrimental, not just to your body, but to your mental health, and then the recovery process, and then finding the right practitioners to kind of, have a team that you feel held and supported. Because generally, I found being a patient of yours, Andrew, is that when you have endometriosis, it can also come hand in hand with other reproductive health issues. Can we touch on some other that kind of go hand in hand with endo?
Absolutely. There's a lot of things that go hand in hand with endo. I mean, some things, there's talk around, some issues like autoimmune diseases. Well, unfortunately, endometriosis is an autoimmune. It doesn't fit that classification. But that's not to say in future it might not. There may be some autoimmune, but we just don't have. It doesn't produce autoantibodies. So we can't pick it up that way, and that's why immunotherapy doesn't work. But there's other things like adenomyosis, which keeps getting overlooked. So histologically, if we took, I've got my uterus here.
Perfect.
Today I have a uterus. So we see endometriosis, which is outside the uterine environment, and adenomyosis, which is deep within the uterine tissue. But histologically, if we took a biopsy of both of those disease states, there's very little difference. And in fact, they are actually one and the same disease states, but they're just in different locations. So they often go hand in hand. So we often see women that will be diagnosed with endo and then have adenomyst, and vice versa.
I remember, I don't know if it was you who told me that they say adenomyosis is endometriosis' evil cousin. Because it's often like
Correct.
you just don't hear about it. Like you hear about endometriosis. We have an Endometriosis Awareness Month, and then you don't hear about adenomyosis as much.
No, you don't. And look, next month is Adenomyosis Awareness Month as well.
This is good to
Yes.
know. See, I have adenomyosis, and I only found that out through Andrew as well. And I had no idea that next month is adenomyosis month. So I then will be obviously talking and promoting that too, because I think a lot of people are just... Because it's just one of those things. It's like a rippling effect, but not necessarily, well, it's not in a good way. It's just like you find out one thing and then it's like, boom, it's another thing. And I find that a lot of people have been misdiagnosed also with mental health conditions when they actually have hormonal reproductive health issues, like me, for example, with my PMDD. Again, I didn't know I had PMDD until I started working with Andrew. And I remember Andrew at the beginning, after my third laparoscopy, I was like, oh my gosh, I'm having these manic episodes. And I would call Andrew or message him or email him being like, I think I've got this. And a lot of doctors, GPs I'd go to would say, yeah, maybe you should go to a psych. It sounds like you're having like bipolar episodes. And I was like, oh my gosh, another thing to think of, to add to this forever ending list. And then I found out, no, it was PMDD, which is also linked a lot to endometriosis as well. And why is that?
It's bidirectional. So because of the way that endometriosis is driven by estrogen, we know that. Same with adenomyosis. But it's the way that it affects your hormone and the hormone pathways. So there's that part of PMDD, and which is premenstrual dysphoric disorder. And I think the biggest problem we see with PMDD and like BPD, which is I'll come back to borderline personality disorder. There you go. Good. Yeah. We often gets misdiagnosed as bipolar, and it's far from it, because a lot of people, it's just without proper diagnosis, they're not getting the right help. And but BPD is a whole different story, but PMDD is really underdiagnosed.
Yes.
Plus the anxiety aspect to it and all the other symptoms that go with it. And it's easy to diagnose. Yeah. All we need is a PMS chart or a PMDD chart and get someone to chart for a month, and then we can actually look and see, those varying symptoms, because you'll only get about, as you may know, 1 week a month where you feel normal.
Well, that's
and
it.
A lot of the symptoms are worse 7 to 10 days prior to a cycle, and then as soon as you get your period, you start to feel normal again.
That was it. I was like, oh my God, wait, I'm back again. It's like you're so disconnected from your body, and you're just thinking that you're a completely different person. Everything feels different, everything tastes different, like you can't hold proper relationships. And then it's like you start to menstruate and you're like, oh, there I am, I'm back again. And it's just this, it's such a wild feeling, but it's so important to know that just because you have endometriosis, that might not be the only thing you have. And that kind of leads me into my next question, which is obviously we know with endometriosis it's lifelong, and to have a management plan. What does a multimodality management plan look like for people with endometriosis, and how important is it for people to know that they shouldn't have to do this alone?
Yeah, look, I think that's with any disease state or health condition. I think a lot of us these days in the information age think we can just Google our symptoms and help
Dr.
ourselves.
Google. Dr. Google.
Dr. Google can be so scary. Dr. Google has sent me to the emergency ward many a times.
Fear-mongering bastard that he is.
Oh, God.
He is a fear-mongering bastard. He is. But how many of us have been down that rabbit hole?
Been there.
It's like, I've got this.
I just saw a skit on a guy doing it, and he was like Dr. Google himself, and a guy came in and he goes, I've just got a sore, and he goes like, oh God, I think you've got cancer. And then it was a very funny spot on skit of exactly what happens as soon as you type in one symptom.
It does.
It's like, you're dying.
you spiral.
You're dying.
And because especially with women and AFAB individuals, is that because there's not so much space held for these types of issues, if you are having a flare-up or a manic episode from PMDD and you don't know you have these things, you go to ER and then they go, oh, we've done all the tests and you've been here for 8 hours and there's nothing wrong with you. So you just feel crazy all the time.
Yeah.
So
Absolutely.
that's kind of where I want people to understand that it is a lifelong condition and having management for it is important. What would you recommend if people assume they have endometriosis or if they already know? What does an endo management plan kind of look like, or any hormonal health plan look like?
Well, I think you touched on, like Dr. Google does cause a lot of anxiety, and what I see in practice is a lot of people, because let's face it, there are, people that aren't identifying as women that now do also have endometriosis.
Yeah.
But there's also that anxiety aspect of living with a long-term health condition and probably being missed and dismissed for many years as well, that adds further to that anxiety and perpetuates that more and more anxiety on top of it. But I think with endo, I always say you do have to have a multimodality team approach, because there's so many aspects to it. You've got the bowel aspect, you've got the mental health aspect, you've got the bladder aspect, then you've got the pelvic floor, because a lot of people's pain with endometriosis may not necessarily be from the disease state itself. It's actually the pelvic floor firing off and causing issues as well.
Yes.
And that's why a lot of them have pain with intercourse. They have bowel issues, pain running down their legs, back pain, coccyx pain, pubic pain, and then that pelvic and rectal kind of pressure feeling they can often have. And
so if you've got any of those kind of symptoms, what happens when a patient presents to you with some of those symptoms, one of them or more? How do you know that it's endo and not, like sciatica or, a weak bladder or, weak pelvic floor or something like that? How would you know that it's the endo? It's a really good question, by the way. And it's something that a lot of people don't ask, because there are clear-cut signs and symptoms of endometriosis. There really are, and we really need more education to physicians around this. And the Royal College of Obstetricians and Gynecologists has those guidelines, by the way, that any practitioner can access. And again, it starts with period pain, ovulation pain, pain with intercourse, bowel and bladder issues, fatigue, because fatigue's a big part of it, infertility, pain on bowel movements, so you've got those starts. And then things like dark and clotted menstrual blood can be a sign of it, with pain as well, and then the mood kind of issues with it. But then it's zeroing in, because interstitial cystitis can cause pelvic pain. It can cause pain with intercourse. But it will have more urinary bladder kind of issues, like frequent urination, maybe pain with urination, urgency to urinate, nocturia, not peeing at night time a lot. So that would maybe, when you do a laparoscope, you should also do a cystoscopy at the same time. So to rule that out. Or you could just do a cystoscopy and rule that side of it. And look, there is endometriosis that can get in the bladder too. Right. It's rare, but we do get bladder endo. So it is rare in there, but it can get in there.
It can get in there.
How far can it go as far as like spreading?
It's found in every organ in the body.
You're kidding.
They found it behind the retina. There was an interesting case that I saw of a non-healing sore on a woman's finger in a joint, kept bleeding. And when they biopsied it was endometriosis.
Oh my God.
On the outside,
That is
or that was on
wild.
the inside? It was presented.
Outside.
So I was going to say, is it
outside.
only on the inside, but can be anywhere? But now there's that one case of it being on the outside.
Yeah, so it can get everywhere in the body, and often is found on the bowels. It can be found on the fallopian tubes, ovaries, and then into the thoracic cavity. They've found it everywhere.
So what do you do with endo? You want to get rid of it? Like you want to scrape that off? Or is it something that you can shrink? Is it something that you can leave sometimes? Or is it like something that you need to get rid of if you've got it?
Yeah, and this is the interesting thing, because there's no cure for it. But this is where surgery is important. So while we might get blood tests later on, the danger for that is that people may then not get surgery to have a look at the extent of it. Although that it could help to say, okay, now we do need to do a laparoscopy and, rule out people who don't have it. But it is important because it can, you can have organs stuck together if you leave it too long.
And the importance of a good surgeon too, because there's some horror stories where you can end up coming out of a laparoscopy a little bit more damaged and hard done by than when you went in. For my first one, I remember that was a horrible experience. And then through education and meeting the right practitioners like yourself, I then, was put in touch with amazing surgeons and gynos. So I think the importance of making sure you do the research right and knowing what surgeons are really good at what they do, because you can get butchered.
It's such a shame that can even happen. The fact that people don't even know what the word endometriosis is or how to pronounce it, that knowing how to find a good surgeon, it might be like looking for a needle in a haystack. That just should not be. Everyone should be of at least a level of, where they're proficient in what they do and really, really good at what they do. And that you can't accidentally come across a bad surgeon. You know what I mean? Like,
no.
You should be able to just find a surgeon and they're all great because they all know what they're doing. And the sad world that we live in is that it's just not the case.
No.
It's not the case. And this is why I tell everyone, look, because there's a lot of, social media and stuff out there. They're just telling people to see an excision surgeon. Now, any surgeon can do excision surgery. Anyone can. But you need to see an advanced trained surgeon because they're better at their job than other people. And they also do a lot more training, and they also have to do at least 100 to 150 surgeries a year to maintain their advanced trained status.
Wow.
But the general public's not. This is not advertised. The other thing you have to be careful of is websites where you see people that have done advanced training in a laparoscopic surgery, which means they've just done a weekend course and watched someone else do some surgery.
Oh my God.
So that's misleading.
Yeah.
In the public system, we have to be aware that most of the surgeons in there are trainees.
Oh my gosh.
Yeah.
I think this also leads on
doctors.
to the fact that you need to have a really good women's health practitioner, aka Dr. Andrew Orr, because Andrew knows, people like Andrew know who the amazing gynecologists are, who the great surgeons are. Everybody that Andrew has recommended to me that I go to for pelvic floor physios Andrew also does acupuncture, which helps with, I wanted to ask that too for people. Why is it important? Because every second week I try to go see Andrew and we do acupuncture on my tummy area, my womb area, and we pretty much do it all over, really. How does that help? I know why it helps, but I want you as a professional to tell the audience, why does that help?
Well, I'm lucky because I've got, your multiple degrees and use, more like an integrative medicine approach where some practitioners won't have that. So I prefer to do everything myself. But it is very important. And look, it was one of the things when I spent time over in China and hospitals over there, that the way they approach things was very that holistic kind of approach, so that mixture of Eastern and Western, like
Love that.
what I do. And the way that acupuncture can help, it's been long noted it's helped with pain. We know that it definitely helps with pain. But it can also help with the symptoms of and assist with mental health conditions alongside medical interventions. But it also helps that microcirculation. So we know that it works on pain receptors. There's a release of endorphins into the system when you have acupuncture. But there's also now research to show that it helps release stem cells into the system too, which then help with the healing process. So there's a lot of things that happen with acupuncture. And even if we look at it on a science perspective, even just puncturing the skin causes it's like a trauma response where the body then goes and wants to try and heal it. So there's that side of it too. But yeah, there's a whole lot to it.
Because I feel like a lot of people wouldn't know that all these other remedies, you don't have to just go to your doctor and get on the pill or get on addicted to pain medicine or, whatever they offer at GPs. There are so many other ways around it to help with your symptoms, because we have a lot of them for my plan, my pain management plan. We've got acupuncture. I used to go see an amazing pelvic floor physio. You've given me a lot of herbs and supplements, and I find for my PMDD and my endometriosis and interstitial cystitis, if you work with somebody that understands you and listens to you and doesn't medically gaslight you, you can create this little plan. And if I look at myself from 7 years ago, I can't remember how long ago it was I was diagnosed. I was 26, I think. I'm bad with math. And to now, even just knowing and the education I've learnt through you and just knowing about my conditions and being pointed down the right path, my whole mental health around it has changed. And I just really hope that even if it's just one little thing people can get out of this conversation that we're having, is just to get yourself a practitioner that really listens to you and knows what they're talking about, because there's not just one answer.
No, there isn't. And this is the hard thing. I tell people, if you're going to travel overseas, if you really want to do it properly and not get yourself into a lot of trouble, you go and get a travel agent who can step you through every step of the way. And that's what I do for people. I advocate for them, plus help them and treat them and do all that. But if they need a good surgeon, because I don't do surgery, I'll find them a surgeon. I don't do pelvic floor physio, so I find them in my network. But we have to be careful when you do it yourself, because you don't know who you're seeing. So there's a lot of people on the medical side that haven't had proper postgraduate training that are saying they're fertility specialists, all kinds, which they aren't. And we have some on the natural medicine that haven't done it, but have just done a few weekend courses saying, I specialise in women's health. No, they don't. And this is where they get into trouble. And so if you've got someone that can advocate for you, and as like and both of you probably know, as having, dealt with women's health issues, every woman's and menstruating person's going to have to deal with some form of period issue at some stage, or have their pelvic floor checked, or pap smears and all that. It's about finding that right person.
Yeah. What you do, I feel, is quite invaluable. How many of you are there? Really? Are like, in Australia, I know you're in Brisbane. I'm in Melbourne. Can I see you? Are you someone that I can see over telehealth?
Yeah, absolutely.
And do you recommend others, or is there you got a league of wonderful gentlemen?
There are.
Kind sir.
Look, if I can see people, I see people from all over the world now with this wonderful medium that we're on now. We can see each other and not be in the same room. So I can help a lot of people that way and advocate for you. And look, if you really need to, I say to people, sometimes it's better to take a day or two out of your life, maybe fly somewhere and get a good job, than stay local, maybe have a bad job, and then have to put up with that for the rest of your life. So it's looking a little bit differently. And I have been training other people up, both medically and some complementary medicine practitioners, to do what I do as well. But, it's really hard. And there are some good people out there, but we really need a network, and link it up. And that's what I'm trying to do at the moment, get a national network of practitioners.
Yeah, that would be really great.
People can go to, and then get a national directory.
Yes.
So that if you are in Melbourne,
then
there's someone down here that you can send me to that has really great credentials and experience and all of that.
That's what we need.
The other question I wanted to know, to ask you, Andrew, is that it all sounds wonderful. Angie and I, we've often speak about this, that having any kind of health problems. In this country, we're very, very lucky, but we still, we're at a time in our lives where we're earning enough money to be able to go and get all these complementary medicines, to get, private health, to have private doctors, to do all these things. What is your advice for someone that doesn't have the means that people like Angie and I now have? Because we were once those people, and you really don't know what to do or where to go. And so what's your advice on that?
Look, it is hard. I've got a daughter in university that's very, she's all about being independent and stuff like that. So it's something we talk about quite often, that, how do people afford it? But, there are cheap, affordable options for private health now. And if you can afford it or find the means to do it, please do it, because the public system is broken. And when you do see someone in the public system, I said, you're seeing a trainee and you see someone different every time. I suppose the hard bit is that there really needs to be more funding, the ways to help some of these individuals that just really don't have those means, because it is we're not as broken as America.
Not even
getting
close.
That way.
Getting that way, but not even close to something like that. And it's often about talking with people as well, like knowing, who to talk, like having these kind of conversations where you ask your friends or your family members or someone that you work with that you admire or, you respect, and you say, I'm struggling with this a little bit, like financially, what to do with my money. When we're in high school, we never get taught how to, balance our checkbooks. We don't get taught how to apply for a job or a savings account, or these kind of things, or what to look at. Like, we do health at school, but we don't get taught about, a reproductive system on a woman going wrong, anything like that. That's like right. That. Wouldn't it be wonderful if we had all these things in? That's a whole other episode. We can have it another time.
It's interesting you brought up that, because there is some literature that says that every woman actually has endometriosis, or the propensity to have endometriosis. And so
sounds like after this episode, I'm believing it 100%.
Yeah, it's a lot. It's the 1 in 9, or 1 in, it was 1 in 10, but now 1 in 9. I actually call BS on it, because if it takes 10 years to diagnosis, or what they're saying 7 or something now, it means a lot of people are being missed, and then there's some not being diagnosed. So I actually believe it's half at least. So look, we find 50% on laparoscope, so there's 50%. So most women are going to need some help, like you're saying, and so having those options, we're waiting on like at the moment, I think the wait list in the public system is about 4 years. Then you could go in and have your first surgery that might be just an investigative surgery. They close you up and then get you back for 6 other surgeries, because that's how they train them. Or you could go and see a good gynecologist and an advanced trained surgeon, do everything properly. But then there's ways to access mental health care plans now with your GP, 6-3 visit. We've got Headspace, like under 25s, you can go and have as many sessions as you like.
We've
so
got physio
there's
as well.
way.
If you've got chronic pain, you can apply for
Chronic pain plans?
Plans.
Yeah.
I've just done one the other day with mine. I'm getting onto. I just did it with this one and that one. It's like we have got the resources. You just have to know that they're there and ask your GP. Another thing, Andrew, that Angie and I have often talked about in the past is how much. Well, what I like to call GPs as gateway doctors. They're your doctor who is there to give you your referral to a specialist who actually knows what they're talking about. The gaslighting, I mean, it's incredible how many times you'll go and see a doctor and they will ignore you or they just simply can't be bothered to help you. For everyone listening that, you know, you must, unfortunately, back yourself and speak up. And a lot of people, even if you need to take someone with you. But there's so many times that a GP, you will walk out of the GP scratching your head going, did you just make me feel like I've not got anything wrong with me? And why am I, you know, just told to go and take some Panadol or lose weight or something like that? Like, we've got to back ourselves, advocate for ourselves with our GPs and say, send me on.
Yeah, it is. And look, we have to look at general practitioners, and it's not putting them down, but they are general practitioners.
Yes.
They're not gynecologists.
Yes.
They're not specialists. They don't have postgraduate training. So working in their scope of practice, and if you are unhappy with the results that you have, talk to a lot of these big groups, have a practice manager, speak to the practice manager.
Yeah, we need to do more of that too. Let them know.
Let them know, and if you're really upset, you can make complaints through the various boards. And it's not saying to make vexatious complaints, because I hate that, or put bad Google reviews just because whatever. But unless you make that complaint and you just go home and bitch about it, they're never going to find out about it. So it's about re-educating that practitioner that you just did the wrong by someone and... You know, you need to go and be re-educated. Don't do it again.
Be better. Get better.
Get better.
Because some of them will get better. Some of them will just let their egos take over and go, F you, I don't care. I know everything because I'm a doctor. But, you know, I think that if we do start talking, and that's why we find this so important to have someone like you on to chat to people can be inspired and aspired to go and do something about their own health, or just chat to someone that they think needs to have a chat, like, you know, to talk to about their health.
We have to let people know that it's not normal. Like, it's just not normal.
And we're told for so long that it was so normal.
Yeah. Well, that's why
and
it's
you're a
important
big advocate for it not. Period shouldn't mean pain.
Period pain. Yes, that's a big thing.
It's not normal.
All over your...
It's common.
Yeah.
It's common.
Yeah, very.
But it's not normal. And if people could see what I see with women's organs and menstruating person's organs stuck together. I mean, it literally, the adhesions and everything, it's a mess in there.
Yeah.
So this wait and see approach, like parents often go, oh, we'll just wait and see. Or we're just talking about practitioners that fob off young teenagers because teenagers are not too young to have endo.
No.
And we've found endometriosis in girls as young as 5 years old.
Yeah.
Accidentally.
Oh,
so...
wow.
Yeah.
So this is the it. And also now, you know, when we've got, you know, the transgender community, I was talking to a friend of mine the other day who identifies as male now, who was previously and has female reproductive organs. And we come up to discussion about pap smears. And he was like, oh, I forgot. I've got to have pap smear.
Still got to do it.
I've got to have a pap smear.
Still have to. Yeah, well, that's it.
And that could be dangerous for someone who is now identifying as another gender, who's completely forgotten about their internal organs.
Yeah.
They could have cervical cancer because they've forgotten.
Well, that's
And
it.
also,
so
when, you
it's
know,
all
it's
important.
estrogen-led. You were saying that when there's a transgender happening, a transition, then the testosterone is the hormone that they would be given. Does that change then in as far as getting endometriosis?
they'll still have endometriosis, and that's what they have to understand is even though they're identifying as one gender or the other, they still will have that disease state and it's never going to go.
Right.
And some of the hormones through the hormone pathway, could exacerbate and make it worse. Sometimes it could probably halt it because they're not getting periods anymore.
Yeah.
It could make some of their symptoms better. But the disease is still there. They can't forget about it.
No.
So it's really important to say, okay, it's great that you're identifying as the gender you like to identify with, but we have to look at you have these organs inside you and then you have a disease inside you and the propensity for that to get worse if you don't get it checked and maintained and managed as we go along. So it doesn't just go away.
No, and as far as treatment goes, hysterectomies, like, is that one of the best things that you could do for, like, if you got rid of your reproductive organs, would that get rid of endometriosis happening in other places?
No. So hysterectomy does not cure endometriosis because endometriosis isn't on, or it can be on the uterus, but it's not in the uterus. So adenomyosis, yes.
Right.
And often I'm more an advocate for someone to have a hysterectomy if they have adeno, because what happens is that the disease has nowhere else to grow but inside the uterus. So then they're up with this big bulky uterus and it's a diseased uterus. And they're bleeding all the time and they're fatigued. They've just got no life. And when they have these, like 9 out of 10 women and menstruating persons will say to me, it's the best thing I ever did.
Yeah.
But if you've got both diseases, you will still have endo, and you have to be remembered. And a lot of people are told, "I'll have a hysterectomy and your endo's gone." It's not true. You've still got endometriosis.
That's wild. See, the more we talk, though, the more we find out all these little bits and pieces that we were told as women, oh, just have babies, or just get on the pill, or just do this, or just do that. And you're just like, oh, my God, so many lies. But that's why it's so important to have these conversations now, is because we're unraveling the lies. We're speaking to people that actually are listening to us, holding us, not medically gaslighting us. I feel like we could probably talk for 18 million years about all the other bits and pieces, which we could probably get you back on again for other chats.
Be happy to.
It was, seriously, it's been so amazing. I personally feel so incredibly blessed to have found someone like you, even though it was through interesting circumstances. My naturopath, sending me to you was the best thing, because I have, been diagnosed with a bunch of things, but at least I know now. And having somebody that listens to me and holds me and sends me and to hold space for me and sends me to the right people, it's just been a game changer. And I think anybody that has endometriosis or any reproductive issue or chronic invisible illness, I wish that you all find your Dr. Andrew Orrs like I have, because I don't know what I'd do without you, Andrew.
Thank you. But it, like you were just saying before, first start, go to GP, I need a referral.
Yes.
And don't leave there till you get one.
No. Get a second, third, fourth opinion. If they don't give it to you,
10.
Go to someone else, because
Go to someone else.
Nobody knows your body
Go to someone else
better than you know your body.
Absolutely.
And there's going to be somebody out there like you that will listen. And for that, I'm
there is always someone that will
forever
listen.
grateful.
I thank you very, very much. It's so lovely to meet you, and it's so wonderful to have you
too.
on the show. Thank you for
It's
taking
my
the time
pleasure.
out of your busy schedule. We really appreciate you for doing
We
that.
do.
Really
And
grateful.
I appreciate what you're doing too. Any advocacy is amazing.
So that's all we have time for today. I mean, we had so much talking. Thank you for listening. We will be back next week. We're going to do a big maths recap because, there's, I think, 1 week left to go with that show, and we can't just leave you hanging. We will be back next Thursday. Please rate and review us if you can. Get in touch with us if you need to. You know how to do it. Have the day that you deserve. See you soon.